Okay. So, good evening, everyone. I welcome all of you on behalf of the Diabetes and Mental Health Interest Group. This is a great initiative by Diabetes India, wherein we always have been focusing on a lot of aspects related to diabetes, but this is a topic that most of the time is left and we do not really discuss. Whereas, now we know that mental health has a huge impact on not only the patient but also his caregivers. And this has a great relationship to the diabetes control that your patient has, because ultimately why we are all talking about diabetes screening, diabetes management, is actually to give him a good quality of life. And whenever we talk of a good quality of life, it is not only the physical quality of life or a life which is, free of complications, but also his emotional health, which is very, very important. A healthy mind in a healthy body eventually leads into a good quality of life. Now, a diagnosis of diabetes usually is often met with, maybe some denial. People do not really want to actually understand that there's a diagnosis of diabetes. Usually, you'll find denial. You'll find people not really complying to therapy. People trying to still go to alternate medicine and all the measures. So, this is something which we are going to discuss, and then we'll be talking about some tools for simple mental health screening, which are very, very important, because your patient has to have a clear understanding and a very stable mind to understand what is needed when it comes to diabetes management. And then also some important issues when it comes to the gender differences. Now we always talk about gender differences in diabetes management, and this is again, mental health is again something wherein there will be some issues which are very specific to women and some issues that may be specific entirely to men. So I think we have a whole blend of topics that we will be discussing, and we have great speakers, our great young faculty who are all charged up to start. And let me introduce my co-chair, Dr. Tejas Shah. Welcome, Dr. Tejas. I'll hand over to Dr. Tejas for the proceedings further.
Thank you, Shalini, and good evening to everybody, to all the delegates who have logged in, and good evening to all my co-speakers who are there today, Dhruvi, Jaideep, and Dr. Lokesh. So as Shalini has set the ball rolling, this is our first CME of the Diabetes and Mental Health Group. It is said that around 25% of patients with diabetes are supposed to have some amount of mental health issues or some amount of mental health problems. And the importance here is to understand that we need to diagnose these problems also early. Because most of the times in a busy OPD, sometimes we quite often miss the common symptoms. We don't pick up the common signs that a patient shows, which tells us that he's suffering or he or she is suffering from some amount of mental issues. And the correlation between mental issues and diabetes is very, very strong, be it in terms of glycemic control, or it could be vice versa, where the lifestyle of a person is being affected because of uncontrolled sugars and causing more stress and distress. So to lay the wasting much time ahead, I am going to call upon our first speaker for today. As Shalini said, we have 3 talks today. Our first speaker is Dr. Jaideep Trevale from Satara. He's very, very senior and renowned diabetologist in Satara and areas of Maharashtra. And he's the co-founder, chairman, organizing secretary of very, very important conference called DCC, which was very successful, which has been doing very well in the last few years. So Jaideep, I hand over to you now for your talk, which is related to diabetes and distress.
Thank you, Shalini. Thank you, Tejas, for this opportunity. Let me share my presentation. Yeah, slides are visible.
Yes,
Shalini, slide is visible?
Yeah, they are.
Okay, great.
Yes, they are.
Okay, good evening, everyone. And my job is to talk on the diabetes distress. So before we start, let's have a look at this picture. This is Siddharth, who is looking at his wife and young son Rahul before he leaves his house and his palace in search of the truth. तो जब से ह्यूमन काइंड ने खाने का प्रॉब्लम मिटा दिया है, तब से लोग स्ट्रेस कैसे हटाए और जिंदगी में सच क्या है और सुखी कैसे रहे उसके पीछे पड़े हैं। और 600 बीसी में गौतम ने भी यही किया। एट द एज ऑफ द 29 he left his house in search of the truth। और जो भी चार चीजें उसने देखी, मिजरी, ओल्ड एज, डेथ एंड मॉन्क, तो ये देखने के बाद वो सत्य की शोध में निकल गए। और जब उनको सत्य का पता चला तब हम बोलते हैं कि वो बुद्ध हो गए। तो पुराने जमाने से वी आर एक्चुअली इन सर्च ऑफ द हैप्पीनेस एंड ह्यूमन काइंड वांट टू गेट rid of this suffering. So with this background, this is my small introduction. So let's try to define the stress. So it can be defined as it is a state caused by being here but want to be there. जैसे तेजस, अभी तेजस को जाना है घर लेकिन अटके है अभी कार में. So that can be a stressful factor. Then stress is a normal reaction the body has when the changes occurs, resulting in the physical, emotional, and intellectual response. It can be also defined as a state of worry or mental tension caused by the difficult situation. But stress is a natural human response. And again, fight and flight response is also stress. So stress has the different definitions. When it comes to the diabetes, living with the diabetes itself is very, very challenging. Now, most of the type 1 and type 2 diabetic patients, if you ask them what is their concern, so two common concerns we can find that they usually worry about the future and the possibility of the serious complication because of the diabetes. They usually experience feeling of the guilt and anxiety when the diabetes management goes off the track. So these are the two common problems type 1 and type 2 diabetic patients face. Then diabetes distress actually involves the emotional symptoms that overlap with the several recognized mental health conditions like depression, but we'll understand that depression is totally different from the diabetes distress. Now, unlike a major depression, diabetes distress does not assume psychopathology. So it is an expected reaction to the diabetes. So diabetes distress is an expected reaction to the diabetes, whereas the depression refers to how people feel about their life in general. So this should be very, very clear in our mind as a treating diabetologist, that diabetes distress is different than the depression. So distress is actually expected reaction to the diabetes. So when we try to define the diabetes distress, it is also known as the diabetes specific distress or diabetes related distress, is an emotional response to the living with the diabetes and the burden of the relentless daily self-management and the prospect of its long-term complication. So this is called as a diabetes. It is basically the emotional response when the patient has to do the multitasking in their day-to-day, choosing the food items, taking tablets on the time, taking insulin, checking of the blood sugars. So this itself is a stressful job, and that emotional response is called as a diabetes distress. It can also arise from the social impact of the diabetes, like a stigma, discrimination at the work or discrimination at the school, then dealing with the other people's unhelpful reaction or their lack of understanding about the disease. Sometimes when the girls get married, then in a new house, she is accepted, but her diabetes is not accepted. So there she is helpless and she don't get help from the other support from the family members. And again, there's some financial implications like insurance and the treatment cost. These all conditions can cause diabetes distress. Now, diabetes distress, it occurs in a continuum and defined by its content and the severity. So it is a continuous process. So sometimes diabetic patients with the diabetes will not be in a distress, but maybe in coming few days they might land up into the distress. So it is a continuum, and the content and the severity also gets fluctuations. It can fluctuate over time and may peak during the challenging periods, like any other stressful condition in their life. It actually goes up. Unfortunately, if it is left untreated, the mild diabetic distress may develop into the serious distress and lead to the depression. Now, how common is the diabetes distress? So, 1 in 5 people with the type 2 diabetes have the high level of diabetes distress, and 1 in 4 people with the type 1 diabetes having the high level of the distress. So, diabetes distress is not uncommon. Now, the pooled prevalence of the diabetes distress in the type 2 diabetic patient in India was estimated 33%. Now, this is very recent publication by the Ratnesh et al. But I feel this number is still uh, feels low. If you look into our day-to-day OPD, probably this number will jump to more than 50%. Now, how diabetes distress impacts the glycemic control or the life of the type 2 diabetic patient. Now, diabetes distress lead to the suboptimal self-management because of the reduced physical activity, less healthy eating, not taking medications as recommended, less frequent SMBG. Then these patients frequently have the higher HbA1c, more frequent severe hypoglycemia, and at the end of the day, impaired quality of life. Now we know a very famous movie called the Titanic, and I hope everybody will remember this picture of the captain when ship is actually sinking, and then he understand that now he's helpless. He can't do anything despite of doing all the efforts. Now he will not be able to make ship sail, and it is going to sink. People are going to die. So this is the captain's last photograph in that movie, that he is just watching helplessly. So now this is very typical state, what is called as a diabetes burnout. So diabetes burnout is the state of physical and emotional exhaustion caused by the continuous distress of the diabetes. So the patients who are in a continuous distress ultimately go into the diabetes burnout. They feel physically and emotionally helpless, feeling of helpless and disengaged from the diabetes management. And these individuals are sometimes described by health professionals like us as a difficult to manage patient, non-compliant patient, unmotivated patient, while actually they are struggling with their long-term conditions, diabetes management, and they're actually burnt out patients. So whenever we see patients in our OPD in future who are actually struggling and feels they are helpless, then we should understand that they are actually burnt out patients. So what are the signs of the diabetes burnt out? They are the disengagement from the self-care task. So they usually skip insulin doses or tablets. They do not follow the advice of monitoring of the blood glucose. They have the unhealthy, uncontrolled eating habit. They usually develop risk-taking behavior, and there is non-attendance, so the poor compliance or the poor follow-up. So these are the patient who says, डॉक्टर साहब हमने सब कुछ ट्राई कर लिया, अभी आप मेरे को मत बताओ, मेरा डायबिटीज ऐसे ही रहता है, मैं सब कर चुकी हूँ, आप इंसुलिन चेंज करो, दवा बढ़ाओ, मैं कितना भी डाइट फॉलो करो, आई एम फेड अप विद द डायबिटीज, मेरा कुछ नहीं होता, ऐसे ही रहता है. So these are the actually diabetes burnout patient. Now, clinical psychologist Dr. William has described they are at the war with their diabetes and they are losing it. So this is the typical psychologist description of the diabetes burnout. So they are at the war and they know that they are losing. So when we try to conceal this patient, this is the usual reply by the patient that I have tried that before, but it didn't work. I stopped doing finger prick because I know my blood sugars will be always high. So these are the common replies by this patient. Diabetes burnout can co-occur with the depression, anxiety, and negative mood. The best way to prevent diabetes burnout is to regular monitor for the diabetes distress. Because if you monitor and manage diabetes distress, this patient will not land into the diabetes burnout. So we should always remember this captain's picture from the Titanic to understand the diabetes distress. Now, how to do and what to do. So this is the 7 A's model of the diabetes distress. This is a dynamic model described a 7-step process that can be applied in clinical practice. It consists of the 2 phases. How can I identify diabetes distress and how I can support the person who is experiencing diabetes distress. So these are the 7 A's: aware, ask, assess, advise, assist, and arrange. and aside. So let's have a quick look in everything. So we need to be aware that diabetic distress can present itself in many ways. Suboptimal A1C, not attending clinic, reduced engagement in the diabetes self-care, ineffective coping strategy for the dealing with the stress. They have the multiple negative life stressor and chronic stress distinct from the diabetes, like the financial problem, unemployment, homelessness, impaired relationship with the health professionals, and appearing passive or aggressive during the consultation. So these are the few areas that, or the signs we should look for to understand or to say that this patient might be in a distress. Now, then we need to ask some question. What is the most difficult part of the living with the diabetes for you? Then what are the greatest concern about your diabetes? How is your diabetes getting in the way of other things in your life right now? So these few questions, if you could ask, we could easily point out who are the patient in the diabetes distress. These questions actually offer the person opportunity to raise any difficulties like emotional, behavioral, and social that they are facing, and they get an opportunity to express how particular diabetes related issues are causing them distress and interfering with their daily life. So unless we ask and give them opportunity, it's very difficult to understand this patient is in a diabetic distress or not. Then how we can assess these patients? Are there any tools? So there are two tools. The first is called as the problem areas in diabetes. That is a PAID. This is a 20-item questionnaire and widely used to assess diabetic distress. Each item is measured on the 5-point scale from 0 to 4. 4 is the serious problem. Score for each item are summed and is multiplied by 1.25 to generate the total score out of 100. With the total score 40 or more indicates diabetes distress. So to understand this, I have provided the link at the bottom. So I will not go into the details. There is another scale which is again widely used. It is called as the diabetes distress scale. It has the 17 questions, and with these 17 questions also we can find out the distress scale. Now, once we do the scaling and we understood that this, or we label this patient in the distress, now we need to go ahead with the advice. Now, when it comes to the advice, most of the time as a doctors, we don't understand what to give advice. So sometimes advices are like this, that someone is dealing with the stress at work. We ask them, okay, stand up, take a walk, get a cab, go to the airport and never return. Because these are the difficult patients. Sometimes we want this patient to go to some other doctor because we are not able to give justice. We are not able to understand what to do with this patient. Now, what type of advice we can give? So when using the PAID question, the score on the individual items are useful because we need to look into the individual questions and the scoring, and then we'll understand the major problematic area for the patient. The first thing, we need to explain what diabetes distress is to the patient, explain the signs and the consequences of the diabetes distress to the patient. We need to acknowledge their significant daily efforts required to manage diabetes. So it's very, very important thing when we start conversation with the patient, that acknowledgement of their daily efforts is very, very important. We need to avoid the negative conversations and we need to make it a normal conversation, avoid the negative comments with them. If the person is self-blaming, focus on what they are doing well. Sometimes patients are blaming themselves. So we need to focus on the positive sides of their behavior, and we need to acknowledge that. Then we need to offer a person opportunities to ask the questions, and we should make a joint plan to move ahead. Now, once we make out the plan, there are the two possibilities. Either we can assist him or we can assign. So assist means we should say them that, okay, I am there anytime for you, I'm available, or simply we have to guide them to the another specialist, probably counselors, psychologists, for the further counseling. And these are the two ways. Now, to come to the take-home message, diabetes distress is an emotional distress resulting from the living with the diabetes and the burden of the relentless daily self-management. Severe diabetes distress affect 1 in 4 people with the type 1 diabetes and 1 in 5 people with the type 2 diabetes and 1 in 6 people with the non-insulin treated diabetes. Greater diabetes distress is associated with the suboptimal diabetes self-management, higher HbA1c, and impaired quality of life. Diabetes distress is sometimes mistaken for the depression. The paid scale is used to identify diabetes distress. Diabetes distress is the best managed with the context of the diabetes care. And although the greater diabetes distress tend to be associated with the higher HbA1c, the optimal HbA1c is not necessary indicator of the low diabetes distress. So it is not that the patients who are in a well controlled of the HbA1c are not at the distress. So we don't go with the HbA1c, we go with the their behavior. So these are the take home message, and this is my closing slide. When the Gautam actually turned into the Buddha, these are the 4 noble truths: that life is full of suffering, suffering caused by the ignorance and the selfish desires. When the ignorance and the cravings are reduced, suffering is reduced, and the way to overcome the suffering is the only part to the enlightenment. So once we understand this diabetes distress, then we should help our patient to come out of that and have a better quality of life. With this, I thank you, everyone. Thank you, Shalini, Tejas, for this wonderful opportunity. And I will stop here. Thank you.
Thank you, Jaideep. I think that was a very crisp but very comprehensive coverage of diabetes distress. These are some things that we commonly encounter in our OPDs. So I think you've really taken us to how to identify distress and then what can we do to actually help our patients overcome this distress. So I'll request you to stay back for the discussion, and we'll have the discussion once all the 3 speakers are done. So with that, let's have Dr. Lokesh Shekhawat, a psychiatrist in our group, who is going to give us some very practical tools on how to identify mental health issues in patients with diabetes. So welcome, Dr. Yogesh, all yours.
Thank you, ma'am. Good evening, all.
Yeah, can you share your slides?
Yeah, I'm.
Are you there? Dr. Lokesh, are you there?
Disconnect.
Dr. Lokesh, are you there?
At least I can see him, but I don't know.
Yeah, he seems logged in.
Freeze हो गए हो.
Freeze हो गया है शायद. Freeze हो गया.
Disconnect हुए रहेंगे.
मैं 1 मिनट बोल देती हूँ. Let's wait for a minute if he is coming back. Otherwise, we can go on with Dhruvi's session and then Lokesh can come in last.
Right.
Otherwise, no, we'll be losing time.
Yeah. There is this diabetes distress score, which maybe we can collect from people and have. I
was just thinking, we can do a study on this in our group, in the mental health group on diabetes distress in our OPDs. All of us can do about 100 each, so that ways we can have a good data of about 1,000 plus.
अभी जो पेपर मैंने कोट किया ना, it's very recent publication, लेकिन उसमें 33% दिखाया है.
Right. So let's do it in our OPDs, North, South, East, West. and see how
Yeah.
things are.
वो ज्यादा निकलेगा, 55% से आगे जाएगा वो।
Easily. Yes.
क्योंकि आजकल तो पेशेंट के साथ कॉन्वर्सेशन इस पे ही होता है, शुगर पे कोई बात ही नहीं करता।
Exactly.
I think should I share my slides till the time? I
Yeah,
think
Yes.
please,
I
you
think
can go ahead.
so. So by the time Dr. Lokesh comes in, let's have Dr. Dhruvi, who's going to talk about gender specific issues when it comes to mental health in women with diabetes. So welcome, Dhruvi.
Thank you, ma'am. Thank you so much. Thank you to the whole entire team of Diabetes and Mental Health for inviting me for this talk. Whenever I've been talking in the time that I share my slides, I would just want to acknowledge the point that even for women without diabetes, mental health is a big issue. And I've been fortunate enough to have a friend, a colleague, a senior, and a mentor like Dr. Shalini, who's always supported me throughout the time. Can you see my slides? I have just been blabbering, but can you see my slides?
Yes, we can.
Okay, thank you, ma'am. So we've been always chatting about how mental health issues are different to women versus men. And one of my very close friends, who is also a therapist, just told me that there is a day which is special for men's mental health. And she said that there is still so much of prejudice and stigma for men to come out and say that they need help with their mental health. And here I am presenting about how women are different than men when it comes to mental health issues. So the question is, are women aware that they have these specific mental health issues, and are women very proactive about knowing and doing something about themselves, and coming out and saying that I need help? So that's a question which is open to everyone listening to us today. Let me tell the audience listening that there is a term which is known as euthymia, and it goes by breaking down the terminology, wherein U stands for wellness, well-being, and general terminology as well, and thyma stands for emotion. And the concept of euthymia meant that you need to have an optimal mental state, or a mood which is a good mood, a good health, or a well-being state. And all of us sitting here are under some or the other stress. Say it's already late and you have to complete this webinar, or maybe you have some pending things that you have to reach somewhere. And euthymia is a terminology which we all need to understand and use for everybody, irrespective of their chronic condition. Diabetes is such a chronic condition that takes a toll in a 360-degree manner, like my very esteemed speaker before me, Dr. Revale, just pointed out, that it is going to affect your mental health, it is going to affect you financially, it is going to affect you physically. So now the science, now the whole community is also focusing on a 360-degree welfare of a person. So we do not call people with diabetes patients anymore. We call them people living with diabetes. And it is of first importance that language matters when we talk to people living with diabetes, be them of any gender, male, female, or others. So euthymia is considered as a very important tool, a very important target when it comes to taking care of people with diabetes. And it is also adding on to the burden of how is quite prevalent in people with diabetes. So consensus paper was also, published in 2019 by a group of esteemed faculties from across India, and they came out to say that euthymia in diabetes is something that needs to be addressed, that needs to be taken care of. Like Dr. Revale already said, that diabetes-related emotional distress is huge, but what are the contributing factors? The number one thing is the burden of self-care. There are also interpersonal issues. The burden of having a spouse with diabetes, the burden of having your elders in the family with diabetes, the burden of having a child with diabetes, and of course, these interpersonal issues. They might not call it a burden, but there is definitely a burnout, because you are somebody taking care of a person with diabetes, or you yourself are a person living with diabetes. The emotional worries are regarding the ability of living and coping up with the chronic condition that cannot be completely taken care of. It can only be managed by a disciplined lifestyle. Relationship with the caregivers and with the healthcare professionals is something of equal importance, and I'll come to that at the end of my slide set. This is a forest plot of all the different various studies that have been done about prevalence of diabetes distress in people with type 2 diabetes. Mind you, we'll not call them patients anymore. We'll call them people with diabetes. And this forest plot also demonstrated that across all of these meta-analysis, diabetes distress was a major concern in people living with type 2, and it had a very high prevalence in the female gender. The overall prevalence being that 55 studies said that the number was somewhere between 36, and we were just discussing that the number is somewhere 33 to 36. Now, even in people living with type 1, be them adolescents and now even adults with type 1 diabetes, because of the better insulinization, people with type 1 have a longer and a good quality of life. But again, the mental stress, the diabetes distress is caused because of feeling powerless, about having to accept that they have to take an injectable therapy for multiple times in a day. They have to monitor themselves multiple times in a day. Even with the advent of technology, the thought and the stages of, say the stages of denial, the stages of fear, the stages of acceptance take a lot of time to come, and people feel powerless in the hands of destiny. The management distress, the hypoglycemia distress, the negative social perceptions that come along with the, label of becoming a person with diabetes, or even yet the society is still labeling them as diabetics. Eating distress that comes along with that, the physician's distress, going to the doctor at regular intervals, having a friend or a family with diabetes, all of these constitute for contributing to the diabetes distress in adults as well as in the adolescents with type 1 diabetes. In a study, the prevalence and a 9-month incidence of elevated diabetes distress was reported to around 42% to 44% respectively in type 1 patients. Now, these figures are very staggeringly high. Now, when does this distress happen? When should we be, looking out for this distress? So it happens at the time of diagnosis with diabetes, and people are in utter denial that I cannot be having diabetes. Your machine is wrong. You have a wrong report. Your lab is incorrect. So there are hundreds of ways that the person who's recently diagnosed with diabetes will come to you and say, I don't have diabetes. Then it also comes again at the time of learning to manage your diabetes. So it's a lot of information, when you're teaching a person on how to live with diabetes. You have to monitor, you tell them to take their tablets regularly, you take them, you might as well have to take insulin at some point of time. You have to monitor yourself, and not just monitor your diabetes, you have to monitor your blood pressure, you have to take care of your cholesterol levels. Now, even when we as healthcare professionals are elucidating it and making a checklist of it, it is a plethora of different checkpoints. And imagine a person who has never been to a doctor, who has just been diagnosed with diabetes, when you're teaching him or her about how to self-manage his or her condition, it is going to contribute to the diabetes distress. Again, at the time of emergence of a complication, distress is bound to happen, and again, people feel helpless. At the time of switching medications, whether you are up titrating them to a better OHA or up titrating them to insulin, when you're down titrating, they're very happy, of course, but there are times when sugars are going to go haywire during festivities, during feasting and fasting. So diabetes distress is going to come when you change the medication or switch the medications. Again, at the time when they're switching healthcare professionals because of migration or because of not being happy. So all of these are going to contribute to the diabetes distress. Now, there are also some points which are going to be very, very specific to the females. Females, I feel, are very precious, very different creatures made by God. And diabetes and mental health are impacting female in a very different condition, in a very different altogether manner. And there is such little published data or very little evidence about how diabetes burnout is affecting females in terms of highs and lows, in terms of, how they themselves are reacting to the fact that they've been diagnosed with diabetes, about how the family members are looking at her, how the society is looking at a woman who's been diagnosed with diabetes, be it type 1, be it type 2, be it, pregnancy and hyperglycemia. All of these stages are adding to the already existing, mental burden that she's having. Now, females are biologically different. They are psychosocially different. They already have to juggle with multiple roles. They are wives. They are working now full time. They are mothers. They are daughters. They have in-laws, parents, kids, and even their husband who's like a kid to, take care of. Women are very vulnerable to depression even without a chronic disorder. Add on diabetes, whenever it is diagnosed, it adds on to this mental distress that comes along with managing the chronic condition. And females are twice more likely than men to have depression. The mental illnesses that are associated with diabetes are depression, of course, diabetes related distress that we just talked about, severe mental illness, eating disorders, again, which are very, very common in females, anxiety, dementia, some adjustment disorders, stigma and discrimination that comes along with the labeling of being a diabetic, and phobias, of course, phobias to, tablets, phobias to, being prescribed insulin, phobia of having a chronic disease to take care of throughout the life. This is again a simple, a Canadian paper that said that diabetes and mental illness in females needed to be addressed, needed to be screened. And the most common ones were depression, followed by eating disorders, followed by bipolar disorder, followed by even schizophrenia. A paper from 2010, a landmark trial in the NIH, said that there is a bidirectional association between depression and type 2 diabetes, particularly in females. And let's see what this bidirectional effect means. So whenever the female is, diagnosed with diabetes, because of the stress of daily diabetes management, because of the difficulty of keeping the blood sugar levels under control, there is occasional tension between the, person with diabetes, the female with diabetes, and the doctor. There is constant fatigue, there is constant exhaustion, and difficulty in making the lifestyle changes that the lady has been, advised. This leads to some sort of a depression, which leads to, again, change in the appetite. There are suicidal thoughts, which leads to a lot of anxiety and nervousness. There is a lot of loss of energy, and which leads to high levels of cortisol, which again adds on to impaired insulin sensitivity or insulin resistance. And there are abnormal levels of norepinephrine and serotonin, again adding on to the hyperglycemia, which is already existing. Another paper is also telling that there is an increased mortality risk in women with depression and diabetes. They both are associated with an increased all-cause mortality as well as an increase on CVD-related mortality. We all know that there is a prevalence of this depression in people with diabetes, and both of them are very complex, and they have a higher prevalence in people with type 1 diabetes. Again, even twice higher in people with type 2 diabetes, maybe because of the number of type 2 diabetes people are more. People with diabetes and major depressive disorder have very poor healthcare outcomes and higher mortality rates. This diabetes distress, like Dr. Rewale just pointed out, is very different. At the same time, might have common traits, but it's different from the clinical depression. And we as healthcare professionals have to understand that they can co-occur, but we have to differentiate and treat them accordingly. Let me talk about, again, females. With the focus on females, let me talk about how the family and friend circle are contributing to, this distress or this mental health issues that are coexisting with diabetes. Family of people with diabetes may or may not understand that what this person is going through. When you say that everybody sitting on a dinner table is having mangoes, but this particular lady is said that mujhe mangoes nahi khani hai, I don't have to have this particular indulgence. It adds on to that burden, and somehow that lady will go into a rebellion. And that is why it also sometimes happens that when you probe a lady sitting, she'll tell and say that maine aaj kuch kha liya tha, ya there was a treat that I treated myself with. Family meals are an example which sometimes add on to the inconvenience or to the distress of that lady who is herself making and responsible for making that meal for everybody according to their choices, and she herself does not indulge into that meal. People with diabetes will benefit when they are discussing their fears, when they are discussing their concerns. Like, there is Alcohol Anonymous. If there are groups, there are communities which talk about, wherever the person feels safe to talk about his or her fears about diabetes or their fears about their mental health. Communication with family and friends and even the spouse sometimes becomes very difficult because they are embarrassed about their situation and they don't know how to speak up or how to express themselves. Specifically with females, it is the thing that they are not able to find out the right words, and the male counterpart in their house and their family or her spouse is not able to lend a good ear to her. In terms on looking at the side of healthcare professionals, even we face significant challenges. We understand that you have to achieve a certain goal. We look at the numbers, we look at HbA1c, we look at the lipid profile, we look at her hemoglobin level. So we even ask her menstrual history, but we do not look at the person. Just simply asking that lady with diabetes as to how are you doing, tell me, irrespective of the numbers, how are you feeling? That is what we as healthcare providers have to understand. We cannot be guilt tripping that lady or that person living with diabetes into telling her, you've made a mistake. Maybe we try and change our language and say that it's okay if you've done this and indulge yourself more this time. Maybe let's try and sit together and understand as to how I can help you if you want to indulge. This is the carb counting, or this is how you take an extra dose of insulin. So there is a diabetes distress 17.8. So there are major sources of diabetes distress which can be addressed and we can identify them. So there is the powerlessness, there is the negative social perception, there is the physician distress, the family and friend distress, of course, the hypoglycemia, the management distress, and the eating distress. These all can be identified as the major sources. You can identify which are the two main or three main or a few main, couple of main sources for distress in that particular lady and address them. So there is a very simple approach of managing this. Improve her self-perception. A lot of females have a very low self-esteem, and add on to that, whenever she has diabetes or she is dealing with this since a very long period of time, she needs a lot of improvement in her self-perception. You can also advise her and give her a lot of better coping skills. You can minimize the burden by teaching her on how to take care of her diet, maybe put her into contact with a nutritionist or an educator who can help her identify how and where are the care gaps and how to address those, and involve the family and involve the partners in these coping up mechanisms. The self-care skills that we can teach this lady are becoming a little more physically active, following good dietary habits, self-administration of the medication. A lot of females that I see have this attention disorder wherein they'll stop taking their insulin or stop taking their tablets because they want attention from their family members or from their spouse, and that leads to a lot of complications. Either the type 1 females land up with DK and the type 2 ones land up with extreme weight loss and osmotic symptoms because of constant hyperglycemia. Self-monitoring is something that we should always reinforce in these females. So a very simple AEIOU approach for optimizing these coping skills are ask and assess their coping skills, eliminate the negative thoughts, internalize positive coping mechanism, observe what is going on regular basis, and upgrade that lady's understanding about what can be done. The simple thing is lend a ear. For any female, the simple answers are listen to her, and multiple changes can be seen if you are just listening to her. Break the changes. If she has been able to make any bad habits, try to listen to her and break those bad habits. Prioritize the actions that are needed for making those changes. Focus on the very bare minimum and very bare essential, and make a complete use of the technology that is available. The targeted areas are to take care of the diabetes related emotional burden, the physician related distress, the regimen related distress, and of course the interpersonal distress. A multidisciplinary approach like the team members and my faculty right now is, emphasizing upon is what is necessary. So with that, let me just come to a conclusion and tell you all that females are a little different from men when it comes to diabetes distress. The best answer is to lend a ear to them, to identify where the distress is, what are the sources of that distress, and maybe again just listen to them. Emotions heal when they are heard and validated. With that, I thank you all for your patient listening and lending me your ear today. Over to Tejas sir and Shalini ma'am.
Thank you, Dhruvi. That was an excellent session. And okay, so let's have the discussion after Dr. Lokesh's talk.
Sure, ma'am. Thank you.
So, thank you. Just stay back. And Dr. Lokesh, welcome. You can share your
Good evening, ma'am.
slides. Good evening.
Thank you, ma'am. Thank you very much. Sorry for the internet
issues.
problem.
No
It
issues.
happened. Good evening, all. And I have been asked to talk about the tools for mental health screening in diabetes. Are you able to hear me? Hello?
Yes, you are audible.
Yeah. So as Dr. Dhruvi has already talked about that diabetes and depression have bi-directional relationship. And I was when I was preparing for this presentation, I came to know that the people with depression have 60% risk of diabetes, and the people with diabetes have they have depressive symptoms. 30% can have depressive symptoms, but 10% can have syndromal depression. So if the bidirectional relationship, probably because of their neuroimmunological or hormonal interactions, very, very surprising. But when we talk about the depression is too common and it has large impact on the patients with negative impact on the lives of the patients with diabetes. So we should be knowing whom you should primarily screen, who are at risk. So people with female gender, adolescent, young adult, or older adults, poverty, few social support, stressful life events, poor glycemic control. If any patient who comes again and again with his diabetes is not under control or experiencing recurrent hypoglycemia, I think we should evaluate him for the mental health issue. Or higher illness burden if there are other illnesses in addition, there is a longer duration of illness, diabetes, and there are complications and physical inactivity, overweight, and hippocampal atrophy. These are the risk factors which makes us to think about if there is any patient who has these kind of risk factors, we should think to screen them for the mental health issues. And why it is important? Because we all know that it worsens the clinical outcome, even because of the depression causes fatigue and the patients are not motivated to do anything. That can increase that can worsen the glycemic control. That can also reduce the adherence with the diabetic medicines. They can have forgetfulness, they can have attentional impairment. Because of that, they can miss the medications. It increases cardiovascular morbidities, and even it increases mortality. So there are many tools related to mental health screening. These are the scales for depression and anxiety. Very simple scales, can be used very easily in the busy clinics even. And the patient health questionnaire, the hospital anxiety and depression scale, Center for Epidemiological Studies depression scale, Beck's depression inventory, these are primarily for depression. GAD-7, the maximum studies which has evaluated the prevalence of anxiety disorders in diabetes has been done with this scale, GAD-7. So the already the previous speaker has talked about the diabetes distress and depression. Diabetes distress is primarily, I personally believe that diabetes distress is like a stress related to any, if they are diagnosed with any disorder, medical, chronic medical condition, they respond with a stress, and that distress, which is specific to diabetes, has been evaluated, can be evaluated with diabetes distress scale or paid. But if there is a depression, we have to differentiate where is the distress and where is the depression. If there is a depression, there will be symptoms related to sleep, appetite, energy levels, primarily emotional symptoms. And I think if we ask two simple questions in the busy clinic, that how is your mood, and how much do you take interest in the activities of daily life. If the patient says, I report I have low mood nowadays and I feel sad, I don't feel like taking, I don't derive any pleasure from any of my daily activities or the things which I used to derive pleasure, I think that is an alarming sign to evaluate for the depressive symptoms. This is PHQ-9, very simple, uh, primarily focused on the feeling of sadness, decreased interest, and feeling tired, poor appetite or overeating. I think it is an overlapping with the diabetes, so it should not be given much weightage. But even then, if anyone these 9 questions, we can, it is a self-report scale, we can give this in the busy clinic outside. If the patients are sitting outside, we can distribute them and ask them to just score whatever they feel. And if the score is more around 5, we should think this there can be mild depression. And if it is the score is around 20, 15, 20, we should think that this patient requires attention for, especially for depression. Similarly, generalized anxiety disorder scale, it has only seven questions, primarily about anxiety. Anxiety is feeling nervous, feeling uh, palpitations, restlessness, feeling on edge, not able to control worries, or maybe worries related to particularly diabetes, that how will this affect my life, or will I be able to have control on it, or how many medications will I require, when will I require insulin, whatever it is. But the worries about this and many questions, if the patient is asking many questions to you regarding their medications, regarding their illness, we can sense the anxiety in the individual, and the people who require assurances many times, I think we should evaluate them for anxiety disorder. Eating disorders, because once we ask the patient that you should not take these all, I think that creates a burden to them, and that increases their preoccupation to take or not to take them. So especially the females of type 1 diabetes, and mm, the people who recently diagnosed with the diabetes, they should be evaluated for eating disorders. And very simple scale, eating attitude scale, which primarily talks about, do you remain worried about how much calories are you taking? Do you make your meals in pieces, or do you remain preoccupied with the food, or do you skip, or uh, take too much food and then you feel guilty of it and then you try to vomit? These are the simple questions which can help us to evaluate for the eating disorders. On then substance abuse, I think that is very important topic, and we should ask many of those patients who are taking alcohol, and uh, alcohol itself is a risk factor for the alcohol itself can complicate the diabetes related complications. And uh, people who take alcohol, I think they are also at risk. If we are prescribing metformin, they are at risk for developing metabolic acidosis. And so we should ask the patient about alcohol, and we can, by these 4 simple questions, each questionnaire, we can evaluate if the patient has alcohol dependence or not. Yes, there's a very simple questionnaire we can ask, that have you ever felt the need to cut down on your drinking? have you been annoyed if people criticize about your drinking behavior? Have you ever felt guilty about drinking? Have you ever felt you needed a drink first thing in the morning? Eye opener. So these are the simple questions uh, which can help us to screen uh, alcohol in the patients with diabetes. In addition to that, I think nicotine dependence is also very important, especially patients who are smoking. We should ask them how many cigarettes are they smoking, they are taking, because that can also not only causes hyperglycemia, chronic hyperglycemia, it can also increase the microvascular complications related to diabetes. Cognitive functions, any patient who is having elderly and taking medicines, and if there are too many medications for diabetes, hypertension, which comorbidities are, and we know that comorbidities are common with the diabetes, we should evaluate them for the cognitive functions also. And especially when if they have chronic hyperglycemia, severe and frequent hypoglycemia, if they have microvascular complications, because whatever microvascular complications happening in retina or in kidney, those are the patients are likely to have those similar microvascular complications in the brain also, and that can cause cognitive impairment. Comorbid hypertension and diabetes, if the patient has comorbid hypertension and hypertension and obesity, they are also likely to have cognitive impairment. A longer duration of illness can also cause cognitive dysfunction. So cognitive, especially uh, MCI and Alzheimer's disease and vascular dementias are more common in patients with diabetes. And these are the simple uh, screening tools like mini mental status examination. This is very simple tool which we can evaluate if the patient is developing any cognitive impairment score. If score is around 7 or less than that, we can think that this patient might be developing cognitive impairment, especially if the patient when the cognitive impairment started, dementia starts in the initial stage, even the family members don't are not able to appreciate. And the simple questions like how what did he take last night, or uh, what is day to day, or what is date to day, these are the simple questions which can guide us the patient is developing any kind of cognitive impairment. If any of those questions patients start missing, or if the family members report that is nowadays he doesn't remember what is the day, what is the date, we should evaluate them for the cognitive uh, impairment with the either with the mini mental status examination on the another scale, that is Montreal Cognitive Assessment Scale. There is little difference between that, but between these two, but MMSE is easier to apply. We can apply MMSE. In addition to that, quality of life also, there are two scales which can be used which assess the quality of life impairment specifically related to diabetes quality of life, and audit of diabetes dependent quality of life. And this is also one of the important thing which I found in the literature, that we should evaluate the beliefs underlying psychological insulin resistance. If the patient, what kind of belief the individual holds when you are changing the medication, if you are shifting him to insulin, then if there is a perception of worsening of illness severity, if you are shifting him to insulin, if because of any reason you are shifting to him insulin, but he may perceive my illness is probably worsening, and they feel that it is the requirement of insulin is like a failure to manage the illness, and it is like they are losing control over diabetes. They have apprehension and anticipated pain or discomfort regarding the insulin injection, and they can also uh, have a lack of personal benefit for the added stress and effort of using insulin, because this causes them added stress in addition to the pills. Thank you very much. Hello.
Thank you, Dr. Logesh. Dr. Tejas?
Yeah.
Yeah.
Thank Shalini, you are muted.
So I think we've had three great speakers talk on different aspects of diabetes and mental health, and I'll hand over to Dr. Tejas for the panel discussion.
So three wonderful talks, three different aspects is what we have seen regarding mental health and diabetes. Tools to identify the right points where we can capture these patients early and target these patients early and treat them in the way required. Women-specific problems, and of course, diabetes distress, which is a generalized condition which might be there in so many people. And as the latest data also suggests, being the numbers being more than definitely 25 to 30%, what the papers are actually suggesting. So we have. Let us start with this. First of all, I don't think there are any questions in the chat box, but request all delegates, whoever are logged in, if they have any queries, any questions, please do post questions to us in the chat box. So, Dhruvi, coming to you and what you spoke about, it is very clear, and we know that women are more prone to depression. Maybe women are more prone to issues related to this. In your clinical practice, do you think, are you seeing this also more, or is it do you think there is nowadays, especially, there is no gender bias much? You see males also equally having these issues. What is your take on that?
So, sir, I have a mixed practice. We have two hospitals, and there are people from the rural areas also, people from the urban areas also. So when it comes to, understanding mental health issues, it is quite pertinent that the social media has penetrated everywhere. Even the rural public is coming to us and saying, that I think that I'm going through something and I think that I need help. When it comes to this gender discrepancy roles, it's very tough to differentiate. Females, even from the urban area, might not come up and say there is still a lot of stigma related to coming up and saying that I'm feeling a little depressed or I'm feeling that there is something wrong. And males across different area geographies and categories, there is still a lot of hesitance in even accepting when you say that I think that there are some depressive signs in you, or your body language is telling us that you do require some specialized care. They would not accept that, and it's a little difficult bringing up the topic that you might need a counselor, that you might need an external help, who is other than us, who would require to give you some advice.
Thank you.
Thank you, sir. Thank you.
I would like to add some point what Dhruvi has said.
Yeah, Jay.
देखिए यार, बचपन से हमको ये सिखाया गया है कि कोई रो रहा है तो कोई लड़का रो रहा है तो अरे हम मारते हैं उसको, इनफैक्ट लड़के को, यार तू लड़की है क्या रोता है? तो males are generally brought like this and they are not supposed to express their emotions. So probably males are also equally depressed, but because of they have more responsibilities, they should not express. That is how the society का जो structure बिठाया गया है, उसमें मेल को हमेशा एक strong ऐसा प्रोजेक्ट किया गया है. But males probably do have the equal depressive component, and unfortunately we could not उसको बाहर भी नहीं निकाल पाते ओपीडी में. So probably we in future we should look into this aspect also.
Definitely. And it would be interesting to screen when what we were talking about some time back, that if we should find out, we should make a screening tool where we screen this diabetes distress. I think it will be important when we come out with the data from there to understand that the male-female ratio also in this.
Yes.
Correct, sir. Yes, sir. But the scenario is changing. A lot of, younger males, the definition of masculinity is changing now. Be it our juniors or, nieces and nephews, they have a very different perception of masculinity and how men are brought up. Of course, our generation has faced a lot of prejudice, a lot of, upbringing troubles, but I think the scenario is changing. And the acceptance also in the metros and in bigger cities is different, but the stigma, as we'll call it, मैं मर्द हूँ, मुझे कुछ नहीं होता वाला, that still exists.
No, but I do agree with you, Dhruvi, because the younger generation is more aware of the importance of mental health. and you have youngsters coming and actually saying that I need to see a counselor and I'm disturbed. They
Yes.
seek help. They understand they need to seek help. But I
Agree.
think it's our generation who've been grown up in that particular mindset, like Jaideep said, who still refuse to acknowledge that there is an issue
Yeah.
that needs to be addressed. Dr. Lokesh, what do you think? Have you seen that kind of a age divide in people who actually actively seek help for all these issues, whether they're the younger generation or the elder generation, self seeking or accepting that, yes, there's an issue which I need help on when it comes to my mental health?
I think both are there. One is prevalence of psychiatric disorder is increasing. We should accept. If we see other disorders like diabetes, prevalence of diabetes is increasing. Similarly, prevalence of psychiatric disorders is increasing. And the kind of functioning we require nowadays, we need higher cognitive function. The more higher cognitive functioning, more demand from the work, more demand in the society. That's that needs a more productivity. And because of that, the people with the younger generation, they are more aware about their illnesses, their definitely they talk more because the stigma and discrimination has reduced from the times when we experienced. Because of that, the initial stage that if we are expressing our anxiety, we are expressing depression, we are expressing that we feel low, is a sign of weakness. From there, this is that it is okay to have a psychiatric problem. That that awareness programs and that awareness has played role. But I personally believe that definitely the psychiatric disorders are increasing, and the demand of cognitive functions in the current scenario is actually burdening our mind with mental health issues.
Thank you so much. So before we just end and sum up, one last clinical question, I think on behalf of all diabetologists, I'm going to ask to you, Dr. Lokesh. We all in our clinical practice face these problems when patient comes to us with drugs like olanzapine and the patient is gaining weight and blood sugars are deranged. We tell the patient to try and change this, but the psychiatrist is not able to change that. Invariably says that cannot be removed for can you throw some light on that, these drugs which are there which interfere on with our blood sugar levels and weight, etc., and how do we deal with this?
I think this is a very collaborative teamwork. What happens? We whenever I usually advise my patients to be screened for diabetes or blood sugar, but what happens? The diabetologist see about the diabetes, the psychiatrist see about the psychiatric disorder. There are many patients, even after having diabetes, I have started them on olanzapine or clozapine, which are notorious to cause diabetes, to for the this poor glycemic control, or can actually increase the blood sugar. But unfortunate part is psychiatric disorders are sometimes too difficult to be treated. Some patients even don't respond to anything. They are responding to olanzapine only, and after that they are working, they are doing well. In that case, it becomes difficult for the psychiatrist to change. If he changes, the entire scenario changes. But definitely, I think when the patient comes to me, I usually try to change one. I give at least 2-3 chances to change the drug so that they don't actually experience this diabetes, because diabetes itself also is similarly problematic like psychiatric disorders. So in that case, I think, you can write a note that this medicine is specially, you can talk to your diabetes that it is causing your glycemic control, the worsening your glycemic control. You should talk to them. Probably they will respond to that. If they don't respond, I usually ask the patients to change their clinician for a while if that is not happening. Because what happens there is that problem is with the psychiatrist also. Some of them may not be able to address the side effects related to the psychiatric disorder, psychiatric medications.
Wonderful. Thank you so much. So if there are no further questions, I think we can end our session today. a big thank you to all our speakers, Jaideep, Dhruvi, Dr. Lokesh. Thank you, my co-chair Shalini, and the entire organizing team, RX Events, and Dr. Bansi, Dr. Amit Gupta, and the entire people behind Diabetes and Mental Group. We promise to come back soon with another seminar, and our next step is to start evaluating in our OPDs with the form that we have thought to design. We will be soon out with that questionnaire, where we want to screen mainly our patients and also the health care workers for diabetic distress. So on behalf of everybody, a big thank you, and bye-bye.
Thank you. Good night.
Thank you
Bye.
very
Good
much.
night. Bye-bye.
Bye.
Bye, Shalini, Dhruvi,
Bye. Good
Tejas,
night.
Bye. Bye.
Dr.
Thank you.
Lokesh.
Thank you, everyone.
Bye-bye.